Today we're going to review the basic approach for incision and drainage of common skin abscesses. At this point in the examination, we've determined that we are dealing in fact with a common skin abscess. We've gone through our differential diagnosis. We've palpated the area of concern and have determined that this is a fluctuant abscess. Key terms that we consider for abscess, incision, and drainage, or I&D, is evaluating for fluctuance versus induration. Induration is when the tissue is very firm, when it's very inflamed. It can be red, it can be hot, it can be very painful. If there's too much induration and not enough fluctuance, this abscess may not yet be ready for incision. The main indications for abscess, incision, and drainage are if we have a palpable fluctuant abscess. Hopefully you can see it's very boggy, fluid-filled. I frequently will refer to this as a water balloon under the skin versus an indurated area. Again, when I don't have a good representation, when you push on it, it's more firm. It may be raised, but it will not have that boggy appearance to it. Another indication for incision and drainage is if the abscess has been attempted to be treated outpatient conservatively with antibiotics alone without resolution, or if we have a very large abscess. In this case, if an abscess is greater than 5 millimeters in size, it can be indicated for I&D. There are a few contraindications to performing an I&D, notably if it's extensively large or deep in the perirectal area or elsewhere that may require surgical debridement and potentially general anesthesia if local anesthesia alone won't be sufficient. If there's a facial abscess in the nasolabial folds, as there could be risk for abscess drainage into the sphenoid sinuses, resulting in septic phlebitis, or if there's hand and finger abscesses that probably should be reserved for surgical or orthopedic consultation. Prior to performing the procedure, it's important to review with the patient potential complications as an informed consent. Complications could include inadequate anesthesia, pain during or after the procedure, bleeding, recurrence of the abscess, septic thrombophlebitis, necrotizing fasciitis, a fistula formation, damage to surrounding nerves and vessels, and potential scarring as well. Before we begin the procedure, we want to go ahead and perform local anesthesia in order to give the patient some level of comfort from this. In this instance, we'll be using 1% lidocaine. There's also 2% lidocaine. Another option would be lidocaine with epinephrine. Epinephrine typically will prolong the duration of the numbing agent and can reduce bleeding by producing local vasoconstriction. One thing with the use of epinephrine, you just want to be cautious of where it's being injected so that's not in a dead end area in order to eliminate or reduce the risk of vasoconstriction and potential tissue necrosis from that vasoconstriction. To draw up our medication, because this vial can be reused, we're going to first use an alcohol pad. We want this to be dry before we insert the needle. We're going to use a smaller or larger bore needle in order to draw that medication up. Frequently, I will pull back on the syringe. I will invert the vial and insert air into, and that allows for an easier drawback of the medication. I'll now put the smaller, usually this is a 25 gauge needle or a 27 gauge can be used. Before I inject this into the area, I want to first prepare the skin, in this case with another alcohol pad. I'll clean the area, skin, and again, we want to allow for drying of that alcohol prior to injecting that medicine. Now that we have prepared the skin with alcohol, I'll go ahead with bevel up, and we want to come in very superficially into the area, being mindful not to inject the medication into the abscess cavity itself. Come along, we want to be conscious to inject the medication within the dome of the abscess, keeping very superficial. Again, this is where our scalpel will be inserting, and we want to have the area as numb as we can. Going too deep within the cavity can result in a premature rupture of the abscess that can be downward into surrounding tissue or outward toward the provider. Now that we have achieved anesthesia, I'm going to go ahead and set out my equipment necessary for this procedure. I like to line things up in order of use. I'll start with my betadine solution that I'll clean the area with, my scalpel to make the incision. I'll put out curved hemostats that I'm going to utilize in order to help break up loculations. In this setting, we're going to use this as our culture swab in order to get a culture. If that's indicated, we'll go over those indications in a bit. And then ultimately, of course, we want to have ample gauze available as well, anticipating potential release of purulent tissue. And then finally, I'm going to set out packing with my scissors, as well as just some forceps to pull the packing out with, which we'll cover in a bit. To start with, first we'll open our betadine swabs. I'll apply this in a circular motion, starting at the area where I'm going to start my incision and work my way out on this into that surrounding area. And I will repeat that times 3. While this is not necessarily a sterile technique, it is still a measure we take in order to reduce any potential further complication of infection from this procedure. Next, I'm going to go ahead and open my scalpel. Preferred scalpels are 11 blade or 15 blade. In this case, this is an 11 blade. Before I make an incision, I want to be aware that the most common cause of abscess recurrence can be due to an incision not being wide enough or over the entirety of the abscess to promote adequate drainage. That's something I want to be mindful of so that when I do make the cut, it'll be the length of that abscess. Also, today we're going to use this cotton tip applicator as a representation for a culture swab. We'll demonstrate how to obtain that culture today. Indications for getting a culture is if we do have a severe local infection, if there are systemic signs of infection, thinking of fever or potential hypotension or other signs that can be present. If the patient has a history of recurrent or multiple abscesses, if there's been failure of initial antibiotic treatment, if we have extremes of age, if our patient is very young or very old, or if our patient is immunocompromised, then we'll want to obtain a culture of the purulent discharge that we are about to get in order to verify the known bacteria and for a run of sensitivities with antibiotics to make sure we have our patient adequately covered. So I'm going to keep this to the side so that it's ready to go at the time of drainage. I'm going to have gauze available on hand. Being mindful, there's a lot of pressure in this area. Prior to performing this procedure, the provider wants to make sure that you are completely prepared for potential abscess explosion. Sometimes as the incision is being made, there can be an extreme release of pressure, which can result in a propulsion of this material outward. Now we're ready to make our incision. I'm going to make the incision distal proximal with reference to myself. And again, we want to make sure that it is into the area and that we are coming far enough along the entirety of that abscess, being prepared, making sure that we are comfortable with the length as well as how well we're able to kind of gape that area out. This is an instance where at this point, nothing is draining from it. Typically, this will be ready to drain very rapidly. I'm gonna go ahead and put my sharp away from me so that no injury is made. I'm gonna initiate drainage with using the gauze. As I get the initial amount of drainage out, this is the point that I'm going to go ahead and obtain culture of that material by getting in there really well and making sure that I am rotating that swab and that it is covered. I'll hand this to my assistant who will put it in the appropriate container so that it can be sent out. Now that that's performed, I'm going to utilize my curved forceps in order to probe the area. We don't want to put our fingers in there for concern of potential sharp foreign objects that may be in relation to this. We can see in this cyst there appears to be a wall similar to a sebaceous cyst. What we can do with our curved hemostats is to try to grasp areas of that wall to break that out, and in this case we can bring it out in its entirety. I'll go ahead and use the curved hemostats to verify that there are no more loculations, that nothing further can be expressed from this area. After breaking those loculations up, I'll perform or repeat good pressure to the area to try to milk any additional purulence from that area. When it's determined that nothing more can be drained out, Now we'll shift to the next portion of this procedure. I'm going to go ahead and place a packing. Indications for packing include if this is a very large abscess, typically greater than 5 centimeters in diameter, or if the patient has comorbidities. For instance, if our patient is diabetic or immunocompromised, we'll go ahead and place the packing material with a sterile packing gauze or iodoform. The purpose of packing, ideally, is to allow for drainage to continue. Our goal here is to allow this abscess to close by secondary intention, meaning we're not going to suture it back up. We're just going to let it heal on its own. However, we don't want it to heal too prematurely, especially knowing that further purulent material could gather and we could have another abscess produce. So in order to place packing, we want to be careful not to touch the packing material at this point with our gloves. Again, trying to reduce introducing any further infection to this area. This is iodoform packing. Iodoform is an antiseptic and can also help against further infection. As we pull this out from the bottle, we identify that we don't want to overly pack the abscess. If we pack the abscess too tightly, it can prevent continued drainage and can result in tissue necrosis from excessive pressure within that cavity. The ultimate point of packing is to keep our wound open. We'll cut this out. We're going to want to leave a total of approximately 1 centimeter of packing outside of the tissue as a wick to allow for continued drainage and something that we can grasp when the patient returns. We're going to insert this by we could use our curved hemostats, or we could use the opposite end of a cotton-tipped applicator, and we're just going to fill that region enough that this will not come off. We'll release our grip on that packing. Release. We're going to leave, again, approximately 1 centimeter hanging out. This will prevent the wound from closing, and it serves as a wick for continued drainage. If the patient experiences any fever or chills, they may need to be seen sooner than later. If there's reaccumulation of pus that does not seem to be draining out, they can be seen. If pain or redness is increasing, that can be concerning. Pain is something that we want to keep into consideration as a relative term because this is an uncomfortable procedure that's performed. Keeping in mind we made an incision into the skin, we probed this area with our curved hemostats. That alone can increase discomfort, especially as our numbing medicine wears off. Packing can increase discomfort as well. And so this is another reason why we want to be mindful not to overpack this area. If the abscess is smaller, if there are no relative comorbidities, the majority of these do not require packing. Packing was done here to demonstrate how it can be performed. That being said, if the patient's pain is getting unreasonable, they should be seen sooner. If there are noticeable red streaks coming proximal from this wound, they can be seen. Or if there's a significant increase in swelling in this area, the patient should be seen. In general, follow-up instructions. We want to see the patient back in 24 to 48 hours, especially if we have packed this. When they come back for their follow-up, we'll just use hemostats to grasp that wick, being mindful that this area can still be very sensitive, and we will just pull this out. Once that is pulled out, we'll reprobe the area. If there is no further purulent discharge, then packing does not have to be replaced. If we're pushing on it and we still have significant purulence erupting from the abscess, we'll repeat the packing material and have them return in another 24 to 48 hours to reassess. We want to encourage the patient, once packing is not replaced, to perform warm, wet soaks routinely until healing occurs, which we would anticipate 7 to 10 days.